Colleen McIvennan. I am an assistant professor in the School of Medicine at the University of Colorado, and I have the pleasure of talking with Dr. Sachin Shah from UCSF. He's an assistant professor in the Division of Hospital Medicine, and he is the winner of the QCOR AHA Young Investigator Award. He provided a great presentation, and he's going to tell us a little bit about his study. Can you give us a little background?
Thanks, Colleen. So our study looked at patients with atrial fibrillation. Atrial fibrillation is treated with oral anticoagulants to prevent ischemic strokes. However, that comes with an increased risk of hemorrhagic strokes, which are often devastating for patients. Currently, the AHA guidelines recommend using the CHA2DS2-VASc score to assess an individual patient's risk of ischemic stroke and offering anticoagulation when that score is 2 or more. However, those scores and that strategy really relies on the stroke rates associated with each CHA2DS2-VASc score. So in the current AHA guidelines, they note that a CHA2DS2-VASc score of 2 correlates with a 2.2% risk of stroke annually. What we did was to look at other studies across the world and found that at a CHA2DS2-VASc score of 2, that rate can vary anywhere from 0.8% all the way up to 3.9%. In our study, we took that variation to its ultimate end, and our results were quite interesting. So first, we found that depending on which stroke rates you think are accurate, the benefit varies anywhere from 0.1 quality adjusted life years to 0.6 quality adjusted life years. That's the difference between 5 quality adjusted life weeks and 7 quality adjusted life months. It's more than a 6-fold variation. The second important finding was that when one uses stroke rates from each of these different studies, one finds that actually the optimal threshold to offer anticoagulation varies anywhere from 0, that means to offer anticoagulation to all patients, up to a CHA2DS2-VASc score of 3, that is to anticoagulate patients with a score of 3 or more. Really, what this study highlights is that 1, we need better stroke risk scores, and 2, that the guidelines need to really highlight the uncertainty with the current CHA2DS2-VASc-based decision-making algorithm.
Thank you for that excellent summary. What would you say are future steps in this process?
I think there are 2 future steps. First, for physicians, it's important to realize that a CHA2DS2-VASc score of 2 probably doesn't represent a bright red line for decision making, that there are patients, specifically older patients who may have a limited life expectancy, patients who have a high risk of ischemic stroke, and patients who otherwise have fewer comorbidities who are right at that threshold, and they may not actually benefit as much from anticoagulation as we think. And that information is important for physicians to really sit down with patients and have that shared decision-making conversation so that patients fully appreciate the benefit with anticoagulation. For researchers, we really need better ways to assess the risk of stroke for any individual patient. So these are the 2 areas that I think we need to focus on going forward.
One of the things that you talked about in your presentation was your mentorship, and you being a hospitalist, also collaborating with people really around the country and around the world. Can you describe a little bit your team and how it came to evolve to be so all-encompassing?
Absolutely. So there are 5 of us on this study. The senior mentor for this study, or the senior author, is Dr. Daniel Singer from Massachusetts General Hospital, who's been a leading expert in atrial fibrillation and the epidemiology of anticoagulation and atrial fibrillation for many years now. Dr. Mark Ekman from the University of Cincinnati has really a deep expertise in decision modeling and helped us to really create a model that could help us to understand what this variation in stroke rates actually means for patients and physicians. We worked with Alan Goh, who has also been in this field for many, many years as an epidemiologist at Kaiser Permanente, and he runs the Kaiser's atrial fibrillation cohort. We also worked with Sarah Asperg from Karolinska in Sweden, and one of the some of the biggest studies in atrial fibrillation come out of Sweden and Denmark. And so, she is also a tremendous asset to our team as an epidemiologist from Sweden.
Wonderful. Well, thank you very much. We look forward to your future work, and congratulations again.
Thank you. This is a really wonderful opportunity.